On behalf of the University of Pretoria, Future Africa, and Ambeth Laboratories, I would like to welcome today's speakers and all participants to the second Health Economics Discussion Forum with non-invasive pregnancy testing, NIPT for short, as a central theme. This, of course, refers to genetic testing. Please note the name change to Health Economics and Genomics Discussion Forum in acknowledgement of the fact that genomics, which is what we want to focus on, is just one component of the encompassing discipline of health economics. Today we will have the first of a planned series of discussions to elucidate the health needs underlying the planning of whether NIPT for all is a pipe dream or an attainable and even an essential health service. Economic sustainability of any program is crucial and will require significant input from colleagues in the fields of health economics and actuarial sciences. The ultimate modeling of alternative cost-effective approaches will inevitably raise a variety of ethical and medico-legal issues, which, apart from service costs, will have to include consideration of access to services, staff training, counselling, possible wrongful birth litigation, etc. We must not forget that the patient should remain the central issue around which the service will have to be designed when we deal with the inevitable crunching of numbers. In this regard, it is refreshing to have input from a patient perspective at the end of today's program. Bear in mind that there are even more pressing challenges and needs to be met for non-healthcare funded patients. And I'm quoting a 2016 paper, The Lived Experiences of Black African Mothers Following the Birth of a Child with Down Syndrome, Implications for Indigenization of Social Work by Mbazima Simeon Matebane. It is the author's observation that the birth of a child with Down syndrome, more so in the historically disadvantaged Black African community, does not only create financial, social and medical burdens for the individual or family, but it also places fiscal strain on the state, as the child will need social assistance in the form of a disability grant, special school, regular medical attention, and in some cases major surgery, as well as institutionalization where there is serious disability. Now, if we go on to Helen, and I remind you, Helen, that when you start speaking, you only have exactly 15 minutes. But let me first say something about you. And it was quite a challenge to abbreviate the abbreviated CVs that were supplied to me. As a scientist, Dr. Helen Malherbe originally became part of the rare disease community in 2004 after the loss of a daughter to trisomy 18, Edwards syndrome. Helen is currently a senior postdoctoral research fellow in the Department of Biochemistry, Genetics, and Biochemistry at the University of Pretoria. Collaborating with colleagues from Health Economics and Actuarial Sciences at UP and UCT, her 2-year study focuses on developing a health economic analysis of non-invasive prenatal testing in South Africa as part of the joint UP-AMPATH Translational Genomics Initiative. Her previous postdoctoral studies focused on quantifying the burden of congenital disorders in the country, following her PhD on the renewed need for the care and prevention of congenital disorders completed in 2017. Helen is an active member of numerous international and local bodies, including the South African Society of Human Geneticists, key World Health Organization panels and committees, and the South African Department of Health Human Genetics Technical Working Group. It is clear from the above that Helen is eminently suitable to be the introductory speaker for today's discussion. What's the problem and why do we need NIPT? Helen, over to you.
Hi, thank you, George, for that introduction, and good afternoon, everybody, and thank you for joining us for this second discussion forum that we're having this afternoon. So I'm just going to be setting the scene ahead of this awesome lineup of speakers that we have this afternoon. And I'm going to be talking about what is the problem? Why do we need something like NIPT? So I'm just going to run through very briefly a few definitions and terminology, what is the context in South Africa, some epidemiology and capacity stats, and then I'm just going to summarize with a list of issues, but probably a longer list of questions, because I'm at the beginning of this postdoc and I have a lot of questions, as I'm sure many of you do too. So to start off with, what are we actually talking about here? What is the portion of the burden of disease that we're talking about that we potentially may need NIPT for? What we're talking about, if you see on the screen, there's a big round circle which essentially represents all congenital disorders and rare diseases. And what we're talking about are abnormalities in structure or function that are present from birth. So otherwise known as birth defects. The term that we use is the WHO term of 2006, which is congenital disorders. Now, the causes of these birth defects or congenital disorders can be many things. It can be 80% of cases genetic or partially genetic in cause. And then there's a small proportion, around 15% in South Africa, that are due to teratogens or environmental issues or abnormalities of the fetal environment. Probably the most well-known teratogen in South Africa is fetal alcohol syndrome, because we have the highest documented rate in the world. But if you look up to the lighter block ahead at the top, we have chromosomal disorders listed, and we have monogenic and congenital malformations. So in terms of the genetic etiologies of birth defects, you can have single gene or monogenetic disorders, which are caused by those single genes, or you can have those that are due to the interaction between genetic risk and the environment. And in other cases, there's many genes involved. What we're going to be talking about today is a small portion of chromosomal disorders. And we're talking about the portion where a whole chromosome may be duplicated or triplicated in the cells of the body due to trisomy 21, which is chromosome 21 or Down syndrome. And there are other relatively common compared to some other conditions, trisomies, which are trisomy 18, which is Edwards syndrome, and trisomy 13. You also do get triplicates of chromosomal disorders as well, and other aneuploidies. So I just wanted to present that so we're all on the same page before we start. You can also see in that second column here that congenital anomalies, which are often stated as the full burden of disease of congenital disorders, are actually only a subset that's essentially covered in the ICD-10 chapter that covers chromosomal abnormalities and so on. And we have a large portion ranging up to 50% of congenital disorders that are not included in that chapter. And then just to explain where rare diseases fit in all this, a majority of rare diseases are also genetic. They just tend to be at a much lower birth prevalence in the population. And so we're talking things like metabolic disorders and very rare single gene conditions. Okay, so what is the situation in South Africa? I thought it'd be useful to throw some stats at you here and just to get the most up-to-date stats I could on everything. So annually in South Africa, we have about 1 million births. It's starting to drop just under 1 million births annually, but according to Statistics South Africa of 2020, which is the most recent report for births that we have currently, it was 954 million. Sorry, just under 1 million, 954,000. Of the pregnant women, of around 1 million, about 70% are accessing at least one ANC, antenatal care visit, under 20 weeks gestation of their pregnancy, and about a third are only accessing that after 20 weeks, with 20 weeks being halfway through the pregnancy. And that is a recorded indicator that has to be recorded in South Africa. There's a little bit more information from back in 2016, where we saw that 75% of women attended more than 4 antenatal care visits. We don't know more recently in the last 5 years or so if that has increased, but we do know that in South Africa since 2017, there are now 8 antenatal care visits recommended in South Africa, with the additional 4 of those are now occurring in the last trimester, just to reduce stillbirths and late miscarriages. We know that in South Africa that the proportion of mothers that are at age 35 or over who are considered of advanced maternal age, this proportion is actually increasing. And based on the statistics from last year, it's coming up to nearly 16% of all pregnancies are for mothers of advanced maternal age. And of course, that comes with additional risks, many of which you'll know. And that does include an increased risk of Down syndrome, for example. Although obviously it can occur at any age, mother's age. Our maternal death ratio is 134 per 100,000. And in terms of stillbirths, I can't give you the rate, but as of 2017, approximately 13,000 stillbirths occurred. And neonatal deaths, which are deaths occurring under 1 month of age, our rate was 11 per 100,000, 11 per 1,000, and our infant mortality rate was 25 per 1,000, and with a total of just under 17,000 deaths occurring under the age of 5 for 2018. So this is a simple snapshot with some key indicators of where we're standing currently in South Africa. But we need to know that where we're heading as well in terms of this considerable burden of disease that we're talking about. This is a rather old graph, but it's one that's changed my life when I saw it and understood it. The yellow bars are actually indicating countries, and literally you go from the least developed countries on the left to the more established industrialized high-income countries on the right, so that you can see that as they increase in development, in degree of industrialization, the infant deaths decrease. So basically less babies die under the age of 1. But what we also see with this line graph going through is that as the number of overall deaths decreases under the age of 1, the proportion of deaths due to birth defects increases. And I've put in a big red arrow to show you where South Africa is at the moment in terms of our infant mortality rate. We're at about 25, using the rate on the left. And you can see you can see where we are now and where we're headed. And we're going to see a much more significant proportion of our infant deaths being as a result of birth defects. Another way of looking at this is using World Bank country classification data. So this is where, depend on annual income and GDP, sorry. You can see that the proportion of deaths per the sectorial breakdown, depending on the income of the country. So South Africa is currently an upper middle income country, and we see somewhere between 9 and 14% of current deaths under the age of 5 due to birth defects. If you look at high income countries like the USA, Australia, the UK, and so on, that proportion is now even further. It's even more like a third of all under 5 deaths are due to birth defects. So this is not an insignificant proportion of deaths that we're talking about here, and it is going to proportionally increase as our country develops. So in terms of epidemiological translation in South Africa, what that actually means is basically the change in the types of diseases that are in the population. And there's lots of lines on this graph, and I can see, sorry that the key hasn't come through properly, but these two lines coming down here are under, the gray line is under 5 mortality rate. So that's how many children are dying under the age of 5. The blue line, how many are dying under the age of 1. So you can see that this was coming down and down since the early 1960s, in fact, and it came down just until the end, well, around 1990 or so. And then we were one of only a few countries in the world where we started to see increases in infant mortality and under 5 mortality because of this blue dotted line, which obviously is HIV infections. And that literally caused us to go in a reverse type of epidemiological transition. And you can even see this pale blue greeny line that goes across, that is life expectancy at birth. So our life expectancy was increasing and then it decreased as a result of HIV. But there's been some amazing work done as a lot of interventions that have been implemented in South Africa specifically for HIV. And as a result of that, we have seen a huge reduction since about the mid-2000s. We've seen a big reduction in child mortality because of these. But what we've seen since 2011 is we've seen a stagnation. We have seen no further significant reductions in infant and child mortality. And one of the reasons for this is that we are not tackling and we're not managing congenital disorders as a whole and ensuring that we have comprehensive genetic services for all. And if we're to get to this infant mortality rate target of 10 per 1,000 live births, which is when everybody, it's an indicator of when everyone in the population has optimum services. If we are going to get there, just moving that line, that small amount from 35 to about 10 it's going to take a lot more work for us to get there. In terms of notifications of birth defects in South Africa, there's been a system implemented and administered by the National Department of Health since 2006. Some of these data were published in 2016 in a report, in a journal article. And you may or may not be aware that in South Africa, we only notify certain conditions for congenital disorders or birth defects, and they're known as priority conditions. I've included a few in this table, including albinism, oculocutaneous albinism. We have a slightly high birth prevalence rate in South Africa, cleft lip and palate, Down syndrome, neural tube defects, that's things like spina bifida and hydrocephaly, and then clubfoot. Also included on that list are microcephaly, congenital infections, congenital deafness and blindness, and so on, as they were specified in the documents of 2001 and 2004 from Department of Health. If you look at the red box here where I've really highlighted Down syndrome, and I've put in estimates here for 2020. So you can see that based on the most recent birth prevalence research data, it's a rate of 2 per every 1,000 live births. That's 1 in 500 births on average. But in 2016, it was reported that only 10% of what we should have expected were actually being notified, because we have at least 2,000 births every year are affected by Down syndrome. And of those, only about 200 were reported or notified. Doesn't mean that the births aren't out there. It doesn't mean that they're not being all being diagnosed, but it just means that just over 200 were actually notified and reported that year. So we're missing some in our notifications. We're probably missing some in our diagnoses as well, due to the challenge in diagnosing Down syndrome in South Africa. So then what are the services that we need, or that we have in South Africa, the genetic services that we need to care for babies and people that are affected or at risk of birth defects and congenital disorders? Well, the main specializations are medical geneticists, the clinical medical geneticists, and genetic counselors. And based on recommendations in 2001, it was recommended that we have 20 medical geneticists per one for every 2 million, and we needed 20 then, so we need 1 per 2 million. The actual number we had in 2001 was 4, and today in 2021, we actually have less than that. We have 9. Actually, that's just reduced to 8 because another one left for the UK last week. So this is the state sector that I'm talking about here. We do have probably double that number, with the other half being in the private sector. But this is what is supporting and providing services for the 86% of the population that are accessing state medical care. In terms of genetic counselors, we see very similar numbers. We should have 80 or 85. We only have less than 8 in the state sector. Again, double that amount in the private sector. So we're really under-resourced. And in terms of medical scientists, we don't know the current number. If you look at this at a provincial level, the situation looks even worse. All of those medical geneticists and genetic counselors are now in the Western Cape and Gauteng only. We lost our one clinical medical geneticist last week from KZN. She was servicing 11 million of the population there. And we've recently also, in the last 2 years, we've lost a clinical geneticist and a registrar to the Free State as well. So as of today, we have only 2 provinces servicing 9 provinces in the country. So things are actually getting worse, and unfortunately not better in the country at the moment. And of course, this doesn't talk about sonographers and other relevant specialities, for example, cardiologists, pediatrics, fetal specialists, and so on, who are also generally, all specialities are experiencing capacity shortages and low numbers. And then just to finish off, I wanted to, after giving you that snapshot picture I just wanted to give you the example of Down syndrome. And what is this burden of disease? Because Down syndrome and the other trisomies are the main conditions where NIPT is primarily used. And with the following speaker is going to explain what NIPT is. So as I've said previously, we have approximately 2,000 births are affected annually by Down syndrome in South Africa. What we don't know is how many of those, what proportion of cases are being diagnosed prenatally. It's likely to be very low, especially in the state sector, but we need those numbers. What proportion of termination of pregnancy are due to fetal anomaly? We don't know that either. It's never been published. We don't know what the burden of disease that is represented in those termination of pregnancies as yet. We know that it's recommended by both the WHO and national health recommendations that there is one ultrasound for every woman at 18 to 20 weeks gestation of pregnancy. However, in practice, we know that's not happening. And in most cases, in states, only high-risk referrals are actually taking place for those mothers to be referred for ultrasounds. And then also of those ultrasounds, what proportion are mothers of advanced maternal age, over the age of 35, those ones that are at greater risk of Down syndrome, as well as for other conditions such as ongoing health issues and illnesses, exposure to teratogens, and so on, or previous history of congenital disorders in the family. We don't know how many of those are actually remaining undiagnosed prenatally in the absence or despite relevant screening. For example, many mothers may go through screening. In private sector, they may have the full remit of 8 antenatal visits, and yet then they have their child is born and only to be diagnosed with Down syndrome or Edwards syndrome or Fetal's after birth. And often it's significantly later after birth. The most recent work on Down syndrome in KZN has shown that the average age of cytogenetic or lab diagnosis of Down syndrome is over 1 year of age. And that was excluding one outlier of a 10-year-old child that walked into a clinic one day and was finally diagnosed. What we don't actually know is the total lifelong cost of caring for a child with Down syndrome, because we know it's costly. And we know in addition to that, you've got the personal burden on the family and the financial burden on the family for out-of-pocket expenses, and also needing a full-time carer for a child with special needs. What we need to know is the total cost and effectiveness and cost effectiveness of NIPT versus the currently available screening that we're going to hear about now in the next talk. How many babies and their families that are affected by Down syndrome aren't receiving the care that they require? And what is the contribution of this collective burden to undiagnosed and unrecorded infant and under 5 mortality rates and deaths? And I think a point that George already opened at the start is, what is the financial risk and cost of missing these cases during pregnancy? And it opens up a huge risk to medical negligence claims for missed diagnoses of Down syndrome and other conditions. And I think that is something that we've got to be very aware of as we go forward and in considering new interventions like NIPT and others. Thank you very much. And we must never forget that care is the absolute and prevention the ideal. We have to care for those that are affected by congenital disorders. Thank you.
Thank you, Ellen. That was admirable that you were able to do all of this in 15 minutes. And it just shows me again the importance of the study that you will be undertaking to assist with the health needs assessment and the cost assessment in this regard. A friendly reminder to the audience to ask questions in the Ask a Live question tab. And we'll try and answer most, if not all, of those questions. Then the way the questions will be dealt with is that we will keep all the questions until the end of the program, deal with the questions at the end of the program, except for Dr. Nicholas Crisp, if we will have a special question and answer session at the end of his presentation shortly. But first, let's move to the next speaker, Dr. Marcel Marburg, will now inform us of the basics of non-invasive prenatal testing and what do the results mean. Marcel is a clinical virologist working at Ampath Laboratories. She completed an MBA degree from the Gordon Institute of Business Science, GIBS, in Johannesburg in 2013, and also has a diploma in HIV management. During 2021, she became involved in the departments of genetics and andrology and is currently heading the reproductive biology arm of Ampath. Marcel, we're looking forward to what you have to tell us.
Thank you very much, Dr. George. Appreciate the introduction and thank you for the opportunity to set the stage today for the discussion we're going to have on NIPT. I'm going to share my screen with you. Just give me a sec. Okay, so let's get right into it. So non-invasive prenatal testing. Now we know that a routine part of prenatal care in the first and second trimesters of pregnancy is to screen our pregnant women. And that is in order to identify pregnancies where there might be a higher risk for the fetus to have certain chromosomal abnormalities. So the most common chromosomal aneuploidies during pregnancy leading to live births are listed in the table below. So we know that chromosomal abnormalities occur in approximately 1 in 150 live births, of which trisomy 21 or Down syndrome is the most common autosomal chromosomal aneuploidy, followed then by trisomy 18, trisomy 13, 47XXY or Klinefelter syndrome, and 45X or Turner syndrome. So if we look at the traditional biochemical and ultrasound screening, we know that this is used to detect chromosome aneuploidies and other birth defects and is used as a routine part of prenatal care in many countries. So you have the blood test for the PAP-A and the free beta-HCG, which is usually done at 8 to 14 weeks and in combination with a nuchal translucency. Done using sonar or ultrasound. And then, of course, also maternal blood test looking for AFP, HCG, and estriol, or called the triple test, done at 15 to 20 weeks. Now, the problem with sonar and maternal serum screening is, of course, that we get high false positive rates using only these methods. And the false positive rate then ranges from 2 to 7%. So previously, if you had a woman with a high risk profile, you would then proceed to invasive diagnostic testing in the form of chorionic villus sampling or amniocentesis to make a diagnosis. So let's compare some of the different options that are available for screening. If we also think about NIPT, and I'm going to explain what NIPT is in some of the following slides, but if we look at maternal serum screening that we've already talked about, the sensitivity is about 90% for trisomy 21, and the false positive rate, as I already said, is around 5%. If we go over to the other screening methods like NIPT or non-invasive prenatal testing, sensitivity for trisomy 21 is in excess of 98%. And you can see that the false positive rate is much lower at less than 0.5% for trisomy 21. If you compare that to diagnostic testing, then it's the chorionic villus sampling and amniocentesis. And of course, the sensitivity of both these tests are very high and the false positivity rate quite low. So that's why it's used as a diagnostic test after getting a screening result that is positive. So what is the clinical use of NIPT? It really offers an intermediate step between your maternal serum screening and invasive diagnostic testing. If you look at some of the testing options that's available when you look at non-invasive prenatal testing, you can choose different options according to what your patient in front of you needs. So you can only use, let's say, autosomal aneuploidies, which screens for the common trisomies 21, 18, and 13. And then you can also add sex chromosome aneuploidies or microdeletions if indicated. And of course, then there's lots of patients that also want to know the fetal sex, and this is can be added as an optional choice. So if we look at the clinical use, I've already said it's commonly used for a screening test, the secondary screening test for trisomy 13, 18, and 21. And a secondary screening test is really a follow-up test that's not diagnostic and offered to somebody that's been screened as high risk on the first test. So that could be a biochemical screen, that could be something abnormal that was seen on the sonar, like an increased nuchal translucency. It can be somebody that has advanced maternal age or a positive family of history of aneuploidy. So you can use it after identifying a high-risk group as well. And then the purpose of the screening is to take the advantage of the high detection rate and low positive rate for cell-free DNA screening or NIPT. And we know that it has high specificity. And this, of course, then leads to a large reduction in the number of unnecessary invasive diagnostic procedures that you would get on your initial screen positive, keeping in mind the false positivity rate of that initial maternal serum screens. So what is cell-free DNA? It is short fragments of DNA that's in the plasma and other bodily fluids. It's distinct from the DNA that's in the cell of the nucleus, in the nucleus of the cells. And then we know that these cell-free DNA fragments are released from all organs during certain processes like apoptosis and necrosis. And the maternal plasma contains cell-free DNA from both the mother, the maternal blood, and also fetal sources. So all the maternal organs will contribute some of the cell-free DNA into the maternal plasma. This includes also solid tumors. And then the predominant source of maternal DNA is, of course, the hematopoietic system. And the predominant source of fetal DNA is the trophoblastic layer of the placenta. So if we look at fetal fraction is a very important measurement when we do an NIPT test. It is the percentage of total maternal plasma, cell-free DNA that is of fetoplacental origin, and it's calculated with the fetal cell-free DNA divided by the fetal and the maternal cell-free DNA, the sum of that. And therefore, the fetal fraction is really a function of both the maternal and the fetal cell-free DNA levels in the maternal plasma. And we're going to look at how these things can influence each other when we look at the fetal fraction. So why is the fetal fraction so important with regards to NIPT? It's a crucial component of sample quality control and statistical confidence. It ensures that the placental cell-free DNA detectable in the maternal plasma is enough or of sufficient quantity to generate a meaningful result. And the minimum threshold for adequate NIPT performance varies per assay, so it's usually between 3 and 4% as a minimum. And with a higher fetal fraction, there's a greater statistical separation between an abnormal aneuploid result and an euploid pregnancy, and that gives you more confidence in the final result. If we get a low fetal fraction, we regard that as the test failing, and it will usually then be sent out not done, and we will ask for another specimen. So what causes low fetal fraction? There's reasons, biological and technical, that can lead to a low fetal fraction. It's interesting to note that in certain studies, a low fetal fraction are associated with an increased risk for having an aneuploid pregnancy. If we look at biological reasons for low fetal fraction, it will include both your fetal placental factors and your maternal factors. So fetal placental can be anything from it's an early gestational age, so maybe there was a miscalculation in the gestational age and the test was taken too early. Mosaicism can decrease the fetal fraction. Fetal aneuploidy will have a variable effect. Triploidy will lead to a decreased fetal fraction, and multiple pregnancy will have a bigger total fetal fraction, but a decreased fetal fraction per fetus. Then on the maternal side, biological reasons for low fetal fraction, maternal weight is one of the most important reasons. The fetal fraction decreases with an increase in maternal weight, but there are also other reasons like active autoimmune disease in the mother, if the mom uses low molecular weight heparin, anybody with assisted reproductive technology like IVF, parity and maternal age can all lead to a decrease in your fetal fraction. So maternal weight, just to reiterate, maternal weight causes a significant influence on the fetal fraction. If you look at that ratio again, you can see that maternal weight will increase the maternal cell-free DNA contribution, possibly due to adipocyte inflammation and necrosis, and this will go with or without a simultaneous reduction in the placental contribution. So it throws out your ratio. So the proportion of women with fetal fractions less than 4% is estimated as at 7% for somebody weighing 100 kilograms. And then if you weigh 160 kilograms, 50% of those women will have a fetal fraction below 4%. So the basic steps of NGS. NGS is quite a long process. It consists of nucleic extraction, library preparation, sequencing and analysis. And the reason why I'm mentioning this is because the turnaround time for these tests are quite long. It's about 10 days. So it's not like a PCR test that you just put up and later in the day, a few hours later, you'll get a result. This is quite a long procedure with many steps. And that's why the turnaround time is 10 working days in most laboratories. So how is the result generated? In a non-pregnant state, the proportional representation of each chromosome in the plasma cell-free DNA reflects the size of the chromosome and the karyotype of that individual. So in an euploid pregnant woman, a deviation from the expected chromosome profile in the plasma cell-free DNA due to excess or deficient cell-free DNA fragments from a particular chromosome would then suggest the presence of fetal trisomy or monosomy, respectively. Eligibility criteria: when can you do NIPT? From 10 weeks of gestation for singleton pregnancies, and then for twin or vanishing pregnancies the same, but not for IVF twin pregnancies conceived with a donor egg or surrogate. And we also use a very special tube called a strep tube that stabilizes that cell-free DNA until the tube reaches the laboratory. So the most important part that I think we want to talk about a little bit is the result interpretation. So a low-risk result with a normal fetal scan, this can be reassuring. A low-risk NIPT result substantially decreases the chances that there's an aneuploid pregnancy, but it cannot guarantee it with 100% certainty. And even with a normal NIPT result, certain obstetricians might consider invasive testing. If you look at maybe the ultrasound findings or a family or medical history or a patient that just wants to know for sure, because we know that false negatives can occur, no test is 100%. If we look at the high risk result interpretation, false positives can also occur, and that is why we always need a diagnostic test to confirm the result. Patients should never be offered the option of termination without confirming the result. And of course, genetic counseling is highly recommended when it comes to these type of decisions that need to be made about a pregnancy. And some parents might decline invasive testing. In those cases, postnatal confirmation should be performed. So how accurate is it? It has a high sensitivity and specificity. It depends on what you are testing for. As an example, the sensitivity or true positive rate is 98%, and the specificity or true negative rate is 99% for Down syndrome. And for the test that we offer at AMPATH at the moment, you can see the different rates there. So it really does depend the sensitivity on what you are looking for and what you are testing for. False positives can happen, and there are many reasons for that. Things like placental mosaicism, a vanishing twin, where there's a maternal sex chromosome abnormality or maternal cancer, where there's apoptosis of cancer cells. It can sometimes cause a false positive. And that's yet again why I need to reiterate that a positive NIPT result must be confirmed with a diagnostic test. Limitations of the test: there are limitations. Of course, it only tests for common aneuploidies and microdeletions, depending on which test option you selected, but it certainly doesn't test for all the chromosomal abnormalities or birth defects and other complications. Then certain pregnancies, like I've already mentioned, twin IVF pregnancies with a donor egg or surrogate is not eligible for the test. Any patient with a malignancy or an organ transplant or a recent blood transfusion will also not be eligible for the test. Testing for sex chromosome aneuploidies is not possible with a vanished twin pregnancy. And then in a small number of cases, the amount of fetal DNA in the maternal blood is not enough for the analysis. And that's when we will ask for another specimen so that we can repeat the test. And then to remember it's a screening test and that you need to confirm the result of a high risk with an amniocentesis or chorionic villus sample biopsy. So to conclude the talk, NIPT is a relatively new test which offers an intermediate step between the traditional maternal serum screening with sonar and invasive diagnostic testing. It has the advantage of higher detection rates as well as fewer false positives compared to the traditional maternal screening methods used. Different testing methods are available depending on the maternal history and, of course, defining on serum screening sonar. So are you just going to do for the trisomies? Are you going to do sex chromosome aneuploidies? Are you going to do microdeletions? And then I think I've said this many times, it's not diagnostic, it's a screening test. It has to be confirmed and combined with counseling, which brings me to the last point, that pre-test counseling of your patient with informed consent is of utmost importance so that the couple can understand what that result of low risk and high risk truly means when it comes back. Thank you very much.
Thank you, Marcel, for your informative presentation about the technical background of the issue we're dealing with. Moving on to the next speaker, we are delighted to welcome Dr. Nicholas Crisp, who will address us on the National Department of Health perspective on first steps towards new technologies. Nicholas is a medical doctor and public health specialist who has for many years focused on health management consulting across the African continent. He was head of the Department of Health and Welfare in the Northern Province from 1994 to 1999. It was during this time that I first met him at an informal lunch with Drs. Johan Appelhoff and Helmut Itzroth at the Department of Health Genetic Services Division, based in Pretoria, together with Professor Philip Venter from the University of the North. Subsequently, Dr. Crisp was a consultant in several African countries, including South Africa, Nigeria, Ghana, Lesotho, Botswana, Namibia, and Tanzania. He led the establishment of the National Health Laboratory Service, the transfer of the medico-legal mortuaries from police to health, the creation of the Forensic Pathology Services, and the establishment of the South African Health Products Regulatory Authority, also known as SAPRA. He is currently Deputy Director of National Health Insurance. Dr. Crisp.
Thanks very much, George, and good afternoon to everybody. Nice to be with you. Thanks for inviting me to join you. So as you heard, I've come a long way with George and Arnold and Philip and others many years ago, and it was fascinating to hear some of the issues in this presentation touching on what we were trying to achieve more than 30 years ago in the old homeland areas and subsequently in the Northern Province with genetic screening and dealing with neonatal birth defects. But where I find myself now, responsible for National Health Insurance, and in fact at the moment as Acting Director General, is a completely different space. So what I thought I would do is just tell you briefly about where we are with the reforms that are planned for the health service and how that might impact on some of these high-end, quite complicated scientific interventions that may sound expensive, but may well end up being the ideal for us going forward. So I think by now everybody knows that the intention is to establish a national health insurance. It is the lever by which we wish to reform the health services. National health insurance is a financing system rather than a service delivery system, but it will steer the changes and the reforms on the ground in the service delivery. So if we looked at Helen's presentation where she showed the maldistribution of resources and the very scarce resources to do the kind of work that we are talking about here, we are hoping that we'll be able to access all of the resources for everybody in the structural design and the way in which we pay for the services going forward. So the idea is to pool the public sector resources into one national fund instead of having it go through the provincial equitable shares into global provincial budgets. And then over time to move the current spending in the private sector into the same pool. And that's a little bit more tricky, or at least different in the way that we would need to do that. But the idea is to get the bulk of the 8.5% of GDP we spend on health services into this common pool called the National Health Insurance Fund. This fund would then be the primary purchaser in terms of health structures and health systems. We talk about a single purchaser model in a purchaser-provider split. And the idea is that the fund will then be responsible for purchasing benefits on behalf of the entire population. And the way in which we define those benefits and provide those benefits, the way in which we pay for them, is what will make the national health insurance different from the way we do things today. Now, I won't go into all of that because it's not specific to this particular discussion this afternoon, but what is important is that in the process, if you look at the National Health Insurance Bill, you will see that there's a section that deals with the Office of Health Products Procurement. So maybe there are two things that are worth just highlighting for this particular talk. The first one is the definition of the benefits and whether those are at primary healthcare level or whether they are very sophisticated at tertiary and even quaternary level. The definition of the benefits that the fund will pay for is important, and the way in which we pay for them is also important, and is the enabling legislation is outlined in the National Health Insurance Bill. The second and important part of that equation is the Office of Health Products Procurement. And that is where the formulary of the products, which means medicines, devices, diagnostics, everything that's associated with the delivery of that set of benefits, will then be procured, and I'm choosing my words carefully because the fund will not purchase anything by way of products. The fund will purchase services, but the service providers will purchase the goods that they need. So the medicines and the devices and so forth. So that's the environment that we're looking at in this discussion, is at what point does this kind of sophisticated laboratory testing and the products that are required for that testing become part of the formulary? And the answer is that just because it is more expensive, and it may not be in the long course more expensive, but even if it is more expensive does not mean that it would be excluded from the formulary for the national health insurance. And the key is the what we call pharmacoeconomics, or the economics of the tests that are going to be done, and whether they are the appropriate technology to achieve the outcomes. So we're talking about health technology assessment, and in the provisions of the bill, particularly in the transitional provisions, we envisage that we will establish, and indeed we are already busy establishing, the capabilities for health technology assessment, which will become more sophisticated. And at some point, the bill says that the health technology assessment must be taken out of the fund into an entity of its own. We know other countries have done this, and we've watched what they've done and how they've done it. Now, this past weekend, we had a conference, a two-day conference with the German government, well, with some people from German educational institutions and laboratories, where we were talking about how we work across the world and across Africa in sharing the expertise for this health technology assessment. Because clearly for us to try and establish this kind of capability in South Africa or collectively across the Southern African continent is not going to be possible in the short term. So we need to use the available resources across the world to be able to do it. So really what we're doing is we're saying the country must be able to purchase these kinds of sophisticated services. We need to know at what point is it cost effective to do so. We need to be able to compare technologies as they arise, and we need to make sure that even if they are expensive on face value at the unit cost level, they may well be economically viable because of the other costs that they prevent downstream because we are involved in prevention. So I think everybody understands that in principle. The question is how, over the next 3 to 5 years, how we set up that capability in the country. I indicated we have already started that. You have to do it systematically. So the pharmacoeconomics has been started. The economics of certain devices is very much in a fledgling state, but we need to move into this in vitro and other laboratory testing environment as well. So I'm going to end there just saying it's a long road ahead of us. The world of healthcare and medicine is not anywhere near what it used to be in the past. There are huge opportunities ahead of us, and we need to make sure that we use all the resources available to us as we move into these health sector reforms. I'll stop there because I know that there are a lot of questions people would like to ask. Thank you very much.
Thank you very much. Thank you very much, Nicholas. The first question, I think you may have answered. Perhaps you would like to add something. How can other sectors, for instance, non-profit organizations, industry and pharma partner with NDOH on improving prenatal diagnosis, including NIPT? Would you like to add anything?
Yeah, just maybe, thanks very much. Just briefly, I think we've all realized, especially now during COVID, that anybody trying to go it alone is missing huge opportunities. And the way in which we've been able to work now during the COVID period together with everybody, NGOs, public and private sector, sharing data, sharing common data platforms and so on, has really changed the way we think about partnerships. So I would really like to see that going forward, we don't try and duplicate or set up parallel structures in government, but use the meager resources that we have and network with everybody, including the organizations you're talking about. So I'm just reinforcing what I said just now anyway in response to that question. Thanks.
Thank you. Then the next question is, this is a tough one. What are the steps needed for NIPT to be considered as an intervention available to all pregnant women in South Africa? I don't know whether that can be answered at this stage, but would you like to try?
Yeah, so I think at the moment, it's quite clear how we go about introducing a new medicine. And we've got quite a clear protocol, which has evolved over a number of years, and it runs through a committee called NEMLAC. So what happens is we have the standard treatment guidelines are developed, and that would be the kind of work that the colleagues who've spoken here this afternoon would be involved in. So you develop that standard treatment guideline, and then any of the technologies, whether it's a pharmaceutical technology or these diagnostic technologies that are involved in delivering that service, need to go into a process similar to what we have in NEMLAC. So they get identified. In this case, in NEMLAC's case, it's essential medicines, and the National Essential Medicines List Committee then interrogates the international literature and then subjects it to a pharmacoeconomic evaluation. That's the early start of health technology assessment. So right now, we don't have a mechanism established for this kind of diagnostics, and we don't have it for devices. But the intention is to create that capacity, and it needn't necessarily be all entirely inside government. So it's early days. It's important that we talk to one another and we make sure that we network and don't duplicate what we're doing.
Thank you. Here's the last question before we release you. What is the timeline for considering feasibility, health technology assessment, for instance, for NIPT in South Africa? How will the consideration of different interventions be prioritized?
Yeah, that's an interesting one. Thanks very much. So everyone always asks about timelines, and it's extremely difficult because it's linked to resources, and the resources are not only money, it's our technical capabilities to do things. There are a number of organizations that we are currently networking with in the public and the private sector. And as I indicate, and that includes universities, and as I indicated, there are some international partners who are interested in helping us. The focus up to now, because of the interest from the pharmaceutical companies, has been on pharmaceuticals. But I think with the kind of enthusiasm that I've seen and the pestering I got from the people who asked me to participate in this discussion, there's no reason why we shouldn't be talking to one another and pursuing this further. But I don't want to give a time frame because there's just so many things that are happening at the moment. But whether we should do it or not, I think is not in debate. We definitely need to embark on this kind of evaluation together.
Well, thank you so much for your contribution today, and we wish you all the best for the road ahead.
Thank you very much. I'm sorry I've got to leave you. A very interesting discussion. Thanks, everyone. Bye.
Thank you. Then, moving on to the next speaker, we are excited to have Dr. Nolithandu Nematsurani from Discovery Health informing us about the evaluation process of new technologies, such as NIPT, by a private medical scheme in South Africa. Nolithandu, if I may call you that, is head of Center for Clinical Excellence at Discovery Health within the Strategic Risk Management Division. She's a medical doctor with more than 20 years healthcare experience. She holds a master's degree in clinical pharmacology and an MSc in biostatistics and clinical epidemiology. In her current role, she oversees health technology assessments, health economics, surgical risk management, clinical policy development, medicines unit, including drug risk management, and the clinical research unit. Her unit is also responsible for the overall clinical strategy for Discovery Health and related businesses. We really look forward to listening what you have to say.
Thank you so much, and thank you so much for the opportunity to be able to participate today. So really grateful for this opportunity. So I'm going to take you through a few slides where I just give an overview of how we assess new technologies. So NIPT would be one of those technologies that we actually assessed way back in 2014, 2015, before we actually implemented a benefit around the same time. So there is a way that we approach new technology. It was quite interesting to listen to Dr. Chris, because those processes are what we also apply in the private sector. And I think for us, the importance of having a clearly defined process, it allows us to almost create repeatable processes that can give us an outcome. So our processes will, the initial process includes a clinical filter. So if someone is wanting to introduce a new technology in the environment and they want funding, we would require that they submit a health technology assessment form, which is completed with all the clinical information that is supporting that particular intervention. So we really encourage people to submit all the available data, because that allows the reviewer to have a holistic view of what is out there. What we also do then, over and above what is submitted, we also do our own desktop research to actually see what peer-reviewed articles are available for that particular technology. And then the process then would be to evaluate the quality and the quantity of the available evidence. And if we are satisfied that there is sufficient clinical evidence of good quality that supports the clinical efficacy or effectiveness of that particular technology, then we would look into putting that through our financial filter. But if a technology does not actually pass that clinical filter, meaning that there is poor level evidence, the case studies, it's 2 patients here and there, so that the quality and the quantity of the evidence therefore would not have met our standards, and therefore that would then be declined and communication would be sent through to whoever is the initiator of that review. So we would not even consider the financial filter, because the first step has not been passed. But if that first step has been passed, then we take that technology into a financial filter. We usually look and say, are there similar technologies or other equivalent interventions that we're currently funding for, and we look at how they are currently priced, and we look at whether there is some price benchmarking that can be done. But where there is obviously a clinical benefit that is assigned to you know, the actual value that, you know, the price of the technology. So it's almost like the reason why we are charging so much money is because you're going to be saving so many babies who have got Downs. You know, we must be able then to go into the data and look at the evidence to support those claims and almost then put a value to whatever the claims are. What we also do, you know, from a funder point of view is that we look at the published clinical data and health economic information, and then we do our own analysis because, you know, sometimes most of the data that is collected is not, you know, from the South African context, and therefore it may not always be fully applicable in our setting. So we usually then test those, you know, we test those assumptions in our own data. So if you say, in your data, so many babies are born with Downs, and then we go to our data and say, well, in our data, X number of babies are born with Downs. So if by doing this test, you're going to pick up X and prevent X complications and outcomes, this is how it will play out. Because whatever that information is, it allows us then to calculate what the estimated, you know, prevalence of that condition is going to be in our setting, and also the budget impacts that, you know, will be assigned to that particular intervention. So that whole process is done by our team. And once the process has been completed and we are satisfied and we have agreed on a particular, you know, reimbursement level, then it moves on to policy stages, where then our teams will put together a funding policy for the scheme to say, based on what we know about this technology, this is how much we will pay, and this is how we are going to pay. I mean, if we think about NIPT, for example, when it came, the funding was initially from medical savings account, available medical savings account, but working with the clinicians in the field, we ended up with a better benefit. But let me maybe give you more details around the process, and then I'll tell you how we landed with NIPT over time. So I think this is just to share with you, obviously, the levels of evidence that we consider, because there's evidence and then there's evidence. You know, we always look at evidence that really has been of good quality. We look at randomized controlled trials. Usually when we evaluate technologies, we look at systematic reviews, and we also look at evidence-based clinical guidelines. So all that we consider high quality evidence. And, you know, therefore, when we interrogate submissions, we look at that quality of evidence, as I already indicated. So I think the clinical filter I've already spoken about, some of the functional components and the principles that we apply when we, you know, evaluate, you know, evidence is really applying evidence-based medicine principles. We'll look at a clinical metrics that actually weighs the evidence that has been you know, submitted. We compile a clinical information summary that summarizes all the evidence that has been looked at, and then we draft our clinical protocols and funding policies to guide the business in terms of how to adopt a new technology. I think what is important, sorry, just going back to this slide, is also just the role of external advisors and associations. When I think about NIPT, I mean, when we introduced it in our environment, there was a lot of discussion that we had with clinical experts, you know, on the ground. We spoke to academics. We spoke to SASWOG, for example, you know, the society that is responsible for drafting the guidelines that, you know, were there to inform clinicians in terms of how to use this new technology. So it is really not just about the desktop research and our own evaluations. We also engage extensively with the clinicians and also the societies to actually guide the implementation of a benefit. The health technology, I mean, the health economics evaluation, it really then takes that initial level of clinical evidence, and then we look at, you know, the incidence and prevalence of the condition. We look at, you know, this is now looking at you know, it's multi-criteria decision analysis that we apply in determining how, you know, we're going to reach a decision around whether we're going to fund and how we fund. And also in our setting, we also then decide, is it going to be limited to specific plan types based on the impact that that particular intervention will have from a cost point of view. So we look at the cost of the new technology, cost of the competitors if they exist, budget impact analysis, looking at the various plan types that exist within our environment. And therefore, we can determine whether it is cost effective and also it is affordable in our setting. And I think if we remember when NIPT was introduced, it was priced at around 7,000 Rand per test. So it was not a cheap test, so it was quite an expensive test to introduce. So we had to think about, how we're going to incorporate it into our benefits, considering the significant budget impact that it was going to have. And I mean, working in this insurance environment where, we do know that some members actually leave their own schemes to join specific schemes if they know that they're going to get specific benefits, which is what we call adverse selection or anti-selection in the insurance world. So we also look at the risk that the scheme would have from an anti-selection point of view if we have got benefits that are structured in a specific way. So I think all this is critical. So, like I said, over and above the clinical filter, the submission from the companies that are bringing the technology, from the doctors that are requesting from the technology, we also look at clinical guidelines or consensus statements that may be put out there. And I think what we did was to look at obviously what SASWOG had put together at ACOG, RCOG. This is obviously the American and the British guidelines, and our own guidelines locally. And we also had detailed and intensive engagements with other local experts to say, how do we actually introduce a technology like this? And the final outcome was that we implemented a benefit across all Discovery Health plans, specifically looking at the biggest scheme, which is Discovery Health Medical Scheme. But we obviously applied some benefit entry criteria, which included biochemistry results that the patient would produce before we can then approve the test. And this was obviously guided by SASWOG guidelines, and whatever we implemented was in accordance with what was clinically appropriate and approved. And I think we've been now having this benefit. Like I said, we first introduced this benefit in 2015. So we've been having this benefit for many years. And what we started with, like I said, we started with the day-to-day benefits, and we moved this to our risk benefits. Right now, members have got access to this benefit from their risk benefits if they meet criteria. What we've also been doing over the past years is to look at newer technologies that have come. For example, there are some limited tests that only look at the T21. So we've also incorporated those at a lower cost, even though we know that they are not as comprehensive as an NIPT test. But in our basket of funding, we've also included some of those limited tests where clinically appropriate, and where doctors and patients have agreed to almost have the limited test done. So I think that's really that. This is my last slide, and I'd be happy to take any questions around our journey with NIPT and also how we generally evaluate new technologies. Thank you.
Thank you, Nalitanda. This was very informative for me, and I found the evaluation process quite impressive, and I learned quite a few new things. Before we move to the questions, we would like to introduce speaker number 5. We are very grateful for Mrs. Anneke van der Wetering, NIPT patient, to share her personal experiences as a patient who underwent non-invasive pregnancy testing, and her presentation is called Personal Experience of NIPT in South Africa.
Good afternoon. I just want to share my screen. Okay, I think it's fine like that.
Okay. Thank you. Good afternoon. I'm Anneke van der Wetering, and I had the NIPT in 2019 when I was pregnant with my 4th child. I was asked by Helen to share my experience of the NIPT, and I'm glad to do so. In 2012, our family was blessed with our 3rd child, Marijke, a beautiful baby girl. Marijke was born in a private hospital in Pretoria via C-section. 3 weeks after Marijke was born, she had a stuffy nose, and I tried to contact the pediatrician that was present at her birth. But she was on leave, so I took Marijke to another pediatrician who gave me something for the nose. When Marijke was 6 weeks old, the clinic sister told me that she thinks that Marijke has Down syndrome. After the necessary tests were done, the doctor confirmed that Marijke had trisomy 21. As you can think, this was quite a shock, especially because Marijke were already 7 weeks old and has already been seen by at least 2 pediatricians. Here I just have to add that we didn't do any screening tests except for the ultrasound that can detect and measures the fluid at the back of the baby's neck with any of our 3 children up to that stage. I'm not sure what the correct medical term for this is. And with this, the gynecologist didn't pick up any abnormalities by the measurement. I was 30 years old when Marijke was born, and at the age of 37, I fell pregnant again. I have a sister that lives in Australia, and she told me that about the NIPT blood test. Because of my age, which was 37 years at that stage, and because of the fact that we already had a child with Down syndrome, we decided to do the NIPT because it was totally non-invasive and it poses no risk to the baby. The fact that we only found out that Marijke had trisomy 21 when she was already 7 weeks old also played a part in our decision. This time we wanted to be prepared. We wanted to know if our 4th child was also going to be born with Down syndrome. Marijke was a very healthy baby with only a small ASD and no other health issues, but we also knew that there were quite a lot of health problems that could occur in babies with Down syndrome. We wanted to give our baby the best possible care from the beginning, regardless the outcome of the screening test. So why did we choose the NIPT? I asked my gynecologist about the NIPT because I heard from my sister about it, and she told me that we could do it, but that she didn't know if the medical aid would pay for it and that it was quite an expensive test. She told me that the NIPT was a blood test where blood were withdrawn from the mom. We didn't consider any other screening tests as none of them provide definite answers, and we would not have taken any diagnostic tests such as amniocentesis as the risks were too big for our baby. So when, where, and how did we do it? In February 2019, I had the NIPT done at an AMPATH lab. I was approximately 10 weeks pregnant at that stage. It was a simple blood test, and it took me about 10 minutes to have the blood withdrawn that was sent in for testing. We paid 7,000 Rand for this test. I'm not sure about the details anymore, but after the test was done, I contacted the medical aid to ask them if I could claim for the NIPT, and if I remember correctly, they told me that I had to have a pre-authorization with a letter from my doctor to claim. So I think my gynecologist was also still quite unfamiliar with the test at that stage, because I'm sure she would have given me the letter as she was also my doctor with Marijke's birth, and she was familiar with my history. So the medical aid didn't pay anything for this test. The results took about 10 days, if I remember correctly. My gynecologist called me with the results, which was low risk for Down syndrome, and that our baby was going to be a boy. on the 19th of August of 2019, our baby Albert Debert was born, a healthy boy of 4.2 kilograms. Now, would a different outcome of the NIPT have made a big difference to us? No, even if our baby would have had trisomy 21, we would not have considered termination. What was the pros and the cons for this NIPT for us? Well, the pros was the fact that it's a very reliable test, that it's completely risk-free for the mom and baby, makes it a much better test than the screening tests that are not always accurate and could be risky for the baby. The downside of the NIPT for us was maybe that it was very expensive and that we had to wait quite some time for the results. But as Dr. Meiberg explained now, this is because of the process that have to be followed for the test. So if I can conclude, I would recommend this test for anyone that can afford to do it, and I hope that it could be made more affordable and accessible to all expecting moms so that they could make the right informed decisions regarding their unborn babies. Thank you.
Thank you, Anneke. This brings it very close to home and makes it personal indeed. And it's always useful for laboratory staff to know that the specimen they're dealing with as a patient on the other end, a human being like their own family, with their own needs, questions, and fears. A question I would like to ask, which need not be answered perhaps right away, but did you receive pre-test counseling before the test was done? So all the limitations and other issues of the test were discussed with you. Otherwise, we can now move on to the question and answer session involving all the speakers except Dr. Crisp. And we would like the panel to participate. I will direct the questions to the appropriate panel member. And I may have a problem reading this from the tablet as I tried this out while Anneke was speaking. The first question is, why is it important to diagnose a condition as early on in pregnancy as possible? Helen, would you like to answer that?
Yeah, sure. I think there's a number of reasons. I'm not a clinician, so any other clinicians feel free to speak up. But obviously from the mother's perspective and the family's perspective, it's important to know what you're dealing with, and also just to know it as early as possible, just so that you can make as informed a decision as possible. And I think that's why genetic counseling is so important. And that's one thing that we did forget to bring up, Annika, so maybe you can respond on that a bit later. But also it just gives a greater opportunity. And then if other options are going to be considered during the pregnancy, if, for example, the termination of pregnancy is going to be considered following invasive testing, which also needs time to happen because certain invasive tests can only be done at a certain stage of the pregnancy, it can be extremely traumatic having a late termination of pregnancy versus an earlier one, which is still traumatic and has a huge impact, but it can be even more so at a later stage in pregnancy. I don't know, Nolo, if you'd like to add something there from a clinical perspective.
No, I think, Helen, you've touched on it beautifully. I think with any early diagnosis and early pickup of the condition, it allows for timeous intervention. And I think when it is done late, there's no proper planning, it may have significant impact because for a mother, for example, who would have opted for a termination earlier on, now they have to discover maybe later on. And I mean, we do also appreciate that a lot of mothers may not actually go the termination of pregnancy route, but if they do know and understand the diagnosis prior to delivery, they can prepare and plan for that delivery with the understanding of what, trisomy 21 means in terms of the healthcare requirements and everything that relates to the condition. So I think it's all of that, and it allows also for the counseling aspects that you are referring to say, how do we prepare the family, not only the mother, prepare the family for the birth of a child who may have specific healthcare needs that would need to be taken care of.
Yes, thank you. Michelle, would you like to answer why NIPT is a screening test and not a diagnostic test?
The problem is that if you look at the false positive and false negative rates, it's certainly not a 100% test. And that's why we recommend a diagnostic test in the form of either a chorionic villus sampling or amniocentesis. Usually it's an amniocentesis that's done just because of, you can only do NIPT from 10 weeks. That takes 10 days. Then the amnio needs to be done. So sometimes, due to the gestation of the pregnancy, an amnio is done. But yes, it's only a screening test due to the fact that it's really not 100%, so it needs to be confirmed.
Yes, and I think also because of the origin of the shed DNA from the maternal side of the placenta. And Naritando, can you answer this one? How much does NIPT currently cost in South Africa and who pays? I don't know if it's a fair question.
No, it's not an unfair question, and I think it's an important question to answer, which is why I was indicating that I think at Discovery we were the first to actually open up funding as an open medical scheme to fund for NIPT back then in 2015. Even though we started with the medical savings and we moved to risk. So unfortunately in South Africa, there isn't, a structured, screening program for Downs. There isn't. And I think Nicholas, unfortunately, he's not here. So it's not funded in the public sector as far as I'm aware. And even in the private sector, it will be based on, because it's not part of the prescribed minimum benefits where there is an obligation for schemes to pay. And therefore it means it will be at each scheme's discretion to fund for it. So I think right now it is funded by whichever scheme has created the benefit. And obviously it will range from whichever company is bringing their various platforms that are available to perform the test. But it is sitting at around 6.56 thousand. But like I'm saying, the limited tests could go as low as 4,000, 4,500. But like I say, we started right up there at 7,000. So in our view, with high volumes of mothers who may benefit from this test, I think the prices would need to go down significantly to actually broaden access to this type of technology. I mean, I don't know if anyone else has got different information around funding in other sectors. I'm not aware of availability, for example, in the public sector, and it's not universally available across the private sector either.
Yeah, an issue of concern to myself is that I think I remember an article by Dr. Mike Urban, clinical geneticist, where he also recollected the promise of access to antenatal genetic services by the Department of Health in the 1970s, and I was wondering whether that is still the situation, and if women are becoming more aware of what is available, whether they will start insisting on having the testing and the counseling, and of course the resources won't be in place. But in any event, the other question to you is NIPT currently covered by Discovery Health for all pregnancies, or does it require a case-by-case clinical motivation? What are the benefit criteria that must be met? Pre-authorization, for instance?
So it is covered across all the various plans, like I said, but members would have to do their biochemistry, their first trimester biochemistry, and then based on the outcome of that, so in fact there are various steps. There's the biochemistry, so that gives us an indication of the risk category where the member falls into, and then based on that outcome, then they can be approved for NIPT. Similarly, if a patient has had, you know, the NT, which is the nuchal translucency scan done by a specialized, you know, a gynecologist obstetrician, so there's a limited number of people who can actually do these proper scans. If there is an outcome there that says, you know, we need to be, you know, proceeding to an NIPT, so we then authorize accordingly. So it's really, and I mean, the guidance, like I said, it was based on what SASWOG had put out there to say what is the, you know, how do we interpret the results of the biochemistry, and how do we then transition members to NIPT. So that is really the stepwise approach, and I think once we have received those test results, then it is approved for the eligible members across the different plan types.
Thank you. There's a question, will such NIPT options be available to rural areas? And it touches upon the question that I asked just recently. Or is the focus for urban hubs for the moment? I don't know, either Marcel or Helen could answer this. Helen?
I think with regards to where it's available at the moment, I'm assuming that, for example, if you're a Discovery Health member, it doesn't matter where you're situated. If you fulfill those criteria from what doctors just said, then you would be able to access it. It would just be the practicalities of what that would have to be done at a local lab and sent off with other blood samples. I'm assuming that wouldn't have an impact. But where it is going to have a greater impact, I guess, going forward in national health insurance, but also in the current state services, that's where it's currently not available at all in state services at all, and obviously very limited availability in private medical schemes. So I think we first of all got to kind of prioritize within state. I'm looking at advanced maternal age and other high risk factors, for example, a family history. But that's all going to have to be taken care of essentially by that process that Dr. Crisp outlined earlier, that health technology assessment, and all the players getting on board and all the processes sorted out before that happens. So I foresee it being a while before it's going to be available in even urban centres for state services. I don't know if Marcel, you'd agree?
I agree with what you said. I think at the moment what we see is mostly, you know, doctors referring almost for that secondary screening where there's a high risk patient, you know, identified with a serum screening or whatever. But it's usually, I mean, it's an insured population where then the medical aid would approve. But certainly we get rural and urban medical aid patients. It doesn't really make any difference. But yeah, I agree with what you're saying.
Can I also just add something? And I mean, it talks to the current limitations in the public sector and maybe in the private sector as well. If you look at the cost of doing the biochemistry test, we know that obviously it has got its own limitations. It's not as accurate as doing the NIPT, but it still is an acceptable screening test. And that is not even done. You know, so we're not even doing the basics right now. So I think to get to the level of doing NIPT, we need to really start thinking about what that down screening program is going to look like. And I think for me, there is obviously also local capability that needs to be built and established to make these, you know, tests much more affordable and accessible. Because if they are coming at a cost that makes them very limited in terms of access, then it really is going to be a long way before we can see the rural patient benefiting, because those patients don't even get the basics right now. I can tell you now, NIPT is like a pipe dream when you think about what you know, they are not getting today. Just proper, you know, even just being seen by a medical person just to palpate, just to do basic obstetrics, you know, care. They're not even getting there. So, yeah.
There's a question here about the lack of genetic specialists in South Africa, and I think that should include counselors as well. How will NIPT actually be interpreted and or initiated by providers?
Can I take this one? Because, you know, when we implemented the benefit, we had to almost go out there and look for genetic counselors and put together a network of genetic counselors. And I think for us, that was a revelation that there isn't enough skill in South Africa. And I think there's a requirement for us to be thinking about, you know, training, broadening the skills, because yes, we're talking NIPT now, but like you rightfully say, it's broader than NIPT. It's just a genetic skills that are required. I mean, we speak about rare diseases in kids, we speak about rare diseases broadly, and we know that there's a limited skill available locally. So it's really about how we then have a focused approach in training, you know, such, people, and making it maybe more attractive for people to actually pursue some of these qualifications, because I think sometimes people pursue the qualifications, they don't find maybe the right space to actually contribute, and therefore it's no longer as appealing. So I think if we make it more appealing, there's a specific role that they play, then it may be something that the universities could take up and train more and create the careers that people feel are meaningful enough.
Yes,
George, if I may just add, just to follow up to Nalu's comment, is we have an issue as well in South Africa where the posts aren't being allocated, particularly in state. So you have people training to be, for example, genetic counselors at a number of centers around the country, and then there are no posts for them to go into in state. And so they're going already into an already saturated private sector, where they can be another private genetic counselor. And in many cases, a lot of genetic counselors are actually having to straddle both of those sectors, where they can only be allocated, for example, a 5/8 position in state, and they have to fill the rest of their, the gaps in salary, so to speak, with private sessions. And I think it's a real conundrum. And for example, the way that we have to advocate for roles in South Africa, even in the provinces where we currently have none, it's a very hard process to encourage people to train if there's not going to be a post for them at the end. And at the moment, it's almost coming to the point of being unethical, where we're training people up and there is no post for them to go to. And then we're losing them. We're losing them to another sector entirely. Lots of them are retiring. And then, of course, we're losing many to immigration, and they're moving to other countries where they are being accommodated and, provided with a post and, positive working environments where they have more help in terms of capacity. So I think there's a lot of fundamentals that we've got to get straight first.
Yes, I would now like to ask Anneke, to what extent did the low risk for your NIPT test alleviate your concerns and stress during your pregnancy? And were you offered any genetic or pre-test counseling in that regard?
No, not anything else except for what the gynecologist told me. I don't know who gives the counseling, like if it's the lab or who should give the counseling, but I didn't have like any real counseling. Yeah, the low risk result, it comforted us. I don't know, because of the percentage of the test, how accurate it is. I had comfort after that result.
Okay, thank you. Then I think we've come to the last question. It seems like the plan is for AMPATH to conduct these types of tests for the whole of South Africa. Well, yes and no. Marcel can answer, but the point is it is already available across the whole of South Africa. If so, this seems like a tremendous amount of work for few individuals, but there's an expansion plan in place for the utilization of NIPT in South Africa. I think that's what Helen's studies will have to clarify. Or is the AMPATH network already capable of handling a countrywide influx, assuming this is a newborn screening goal? Helen, would you like to answer that?
That's quite a big question, George.
Sorry?
That's quite a big question, George. Sorry, Marcel, did you have something?
Yeah, I just want to maybe say that AMPATH are one of the providers of NIPT, but certainly there are other private sector labs that do offer NIPT. So we're not the only provider of NIPT, and it works on a referral basis. So obviously obstetricians will send us a patient that needs NIPT. Yeah, certainly we're not the only provider.
Can I ask a question maybe to Marcel? I'm sorry. I mean, we've spoken about local capability, pricing. How do you see, because I mean, like I'm saying, the NIPT was introduced a few years back now. Are there any plans of really making these, these tests more affordable and more accessible?
I think as a laboratory, we're always looking at ways to increase our efficiency and, obviously with economies of scale, sometimes you can get added benefits that the price can maybe be reduced. But at this point, we know that it's a technically very complicated test. It uses quite expensive reagents and kits and instrumentation and highly qualified medical scientists to actually run these tests. So I think those are some of the challenges that we have with this test. But certainly, I mean, just looking at how much a test costs in terms of the kits is already very, very expensive. So you can only hope that also, some of the overseas players might come to the party and make some of those components a little bit more affordable, which can then have that knock-on effect. But the reason why it's so expensive is because of, just what you need to do that test. But we can hope for the future.
You may know about the Invitae pricing that was quite appealing to most of us. I mean, it was sitting at around, I think it was $99, which was much cheaper than what what we were currently paying. Any comments or thoughts around that type of pricing and how that, that could play out in our setting?
Yeah, I think the Invitae model is an interesting one. I do get the feeling that they're trying to sort of crush the competition in local markets. We're trying to also build capacity locally, and I think that's an important thing to also just keep in mind. Sometimes some of the big players overseas tend to offer it at a very low cost to developing countries so that they can sort of, not make it worthwhile for us to actually build that capacity locally. But as AMPATH, we feel very strongly about building that local capacity, because of course, if you kill all the local players in the market, there's nothing that will stop Invitae in future from saying, okay, now you guys are going to have to pay the normal price, and then we will find ourselves in a bit of a bind. So it's an interesting competitive environment at the moment, but like I said, I think it's important for us to really build that local capabilities.
Naritondo, in the absence of the standard health technology assessment approach for devices and technologies, including for NIPT in South Africa, as indicated by Dr. Crisp, what's the status quo for Discovery members or other medical schemes who request NIPT?
So for us, we've been doing HTAs for a very long time because I work for the administrator, and it is my duty to make sure that, we fund appropriate care for the schemes. So we have got an in-house health technology assessment unit, though it may be small, but obviously we're servicing, the medical scheme members. But we do know that, there's a requirement for a unit for the country. And I think, like Dr. Crisp has said, there is a lot of discussion. I mean, they've also approached, private sector players in this regard to say, how do we build the HTA capability for South Africa? But in the private sector, I think, I mean, we are doing our own. We do devices, we do diagnostics, we do medicines, we do everything because it is a requirement for the schemes for us to actually perform that function. But it does not extend to the public sector because whatever we do for our schemes. And remember, even the data that we reference in terms of budget impact and prevalence, we will use the discovery data to estimate some of those. But we're hoping that, you know, because HTA really is an important lever for NHI, we are hopeful that, you know, national capability is going to be built for doing HTAs in the long term.
Thank you. Let me also just add to the in vitro question. They indeed follow a business model which we don't quite understand, but there is an advantage to having tests done locally with the doctor and the counselor and the geneticist and the laboratory scientist in close collaboration, and to deal with any issues that might arise from the test, apart from the fact that there's empowerment of local scientists. We always just felt that we would like to try and not export tests and see technology pass us by. But of course, in the end, costs are crucial. And in this regard, if the further study of NIPT feasibility across economy of scale and perhaps with overseas funding will allow more non-healthcare funded patients to be included, that would be a very satisfying outcome. Anyway, there's another question here. What is the cost of cytogenetic testing? This is the traditional chromosomal analysis across South Africa. And how does this testing service work in absence of financial resources or insurance? As far as I'm aware, there isn't usually a problem to fund chromosomal analyses. Marcel, I don't know if you would like to add anything.
I'm not exactly, I'm sure, Dr. George. I think it's important if somebody is uninsured to actually, you know, if you must get a quotation from the lab so that you know what sort of you're letting yourself in for. If you should pay upfront or be responsible for that payment. So most laboratories will be able to give you a quotation in the private sector so that you can see what the cost of that test is.
Helen?
George, if I may just add something, and it relates to this question and a few of the earlier questions, and then Annika's feedback explaining that she didn't actually receive any formal counseling from a genetic counselor, and she was just limited to what she was told by a gynecologist. Wearing my other hat as a patient advocate and working, well, affiliated with Rare Diseases South Africa, it's actually something that we come across a lot more often in the private sector than in the state sector, because the referral systems are, they have their challenges, but patients do tend to get referred straight to genetic counseling in the state sector, whereas perhaps it's for the reasons that you've just outlined, Marcel, in that it's the patient's responsibility to, find out about the genetic counseling and see if it will, can be covered by discovery. And when you're in that type of situation and you're facing all of these other issues that you know nothing about, that you've got to find out about something that you don't know about. You can only know about what you know about. And you're not going to necessarily know that there's something out there called genetic counseling that you actually could really benefit from, to learn about the prognosis, the future management, risk of reoccurrence, the family history, and so on. And I think in that regard, that the private sector does place a lot more responsibility on the patient. And we do have that patient charter in South Africa that looks at the responsibilities of the patient just as much as the clinician and the HCPs. But it is an interesting point, and it's one that we have noted, and we're not quite sure what to do with that observation. If it's something that can be taken up by providers like Discovery and other schemes, or if some kind of a referral network can be instigated in the private sector.
Can I just comment quickly on that, Helen? I must say a lot of our results, if there is a high-risk result, etc., gets phoned to the doctor, and then we usually do tell them, or they are aware that, you know, we do have genetic counselors available. So, and then we usually tell them, you know what, if your patient needs to talk or you need a genetic counselor, just let us know that we can set up an appointment. So the support is there. I think it's just the questions of the clinician really also telling their patients that the service is available.
Can I also just say something that's quite interesting, Helen, about NIPT specifically? I do believe that some of the obstetricians believe that they've got the skill to actually do the counseling. So I think that's why in some instances it actually doesn't happen in the NIPT space. I think for other, you know, genetic testing and, you know, where they feel that maybe the skill is limited, that's where maybe genetic counselors are, you know, are used. But I do have a sense, and I think even in our discussions when there was that, you know, communication that says, you know, some of the obstetricians are comfortable to actually do the counseling themselves. So I think, you know, it's also just understanding how the doctor actually handled that whole counseling session. And if then it is substandard, that's where, you know, we would say maybe there's a requirement for additional counseling by a genetic counselor.
I think what has become very nice during this time of COVID is that the genetic counselors are more accessible. You don't necessarily need to be in Centurion or Johannesburg or Pretoria to have access. You can literally do a virtual meeting as well. So I think that's also made accessibility in the sort of scarce resource being our genetic counselors more accessible to our patients.
There's a question, Marcel, whether NIPT can be used to test for rare diseases such as single gene disorders.
No, the NIPT that we do is for those specific chromosomes of that list that I showed you. So it would be the trisomies, there's certain microdeletions, and there's certain sex chromosome aneuploidies, but that is what's included in the panel. So if you want other specific testing, then unfortunately you would need, you know, other testing modalities. NIPT does not cover that.
And another question, and I know I said we were at the last one some time ago, but I didn't realize there was still sufficient time. This question is, does South Africa use alternative methods outside of cytogenetic testing for the confirmation of Down syndrome, such as qPCR approaches? Marcel?
We do have qPCR. Usually it's used in neonates or in babies that you want to confirm. But I mean, when a patient, you know, wants to know more about the test, usually we will confer with the doctor and decide on the appropriate thing to do at that stage. So yes, we have a full range of genetic testing available at AMPATH and a full testing menu. So yeah, usually we will talk to the doctor and decide what is appropriate at that stage of the pregnancy or if the baby is already born.
Okay, now this is the last question. Will other tests be offered in the future? Not really an NIPT relevant test, but it may have clinical significance. I'm not sure whether it says ApoL1. I don't know whether it was ApoE, risk allele testing. We certainly, I'm not sure about this question. Can we get some clarification?
I think what this question actually raises is talking about other types of genetic testing in South Africa, essentially, other than NIPT. And currently, I understand that a list is being built countrywide of what is available in terms of genetic testing by South Africa, because obviously the labs, you have your own lists and so on, but there's no formal centralized list of what genetic tests are available in South Africa to anybody at the moment. I do understand that this is being undertaken by the Southern African Society of Human Geneticists, and there's a focal person that is starting to compile this list. And I think it's the question that everybody wants to know: is there a test available for the condition that my child is, is potentially affected by, or is thought to be affected by? And I think it's something that parents and families in infinitum are always going to want to know that. And at the moment, even the clinicians don't know, or even a laboratory scientist at a specific lab may not know what else is available in the country, because we don't have a list. There was a quite an old booklet, a hard copy booklet that was published by the National Department of Health. I forget the year, but it's a couple of decades old. And of course, it's something that goes out of date very quickly. And in terms of some tests, the menu of tests that are offered by a lab may not include everything as well. So I think it's going to be a very important step to get that, that list together, to find out what actually is available here, because we do have situations where people are sending samples overseas when they can have tests done here. And I mean, we need to build up that capacity locally, but there are going to be some tests that are already cheaper to do here, and they're not necessarily being utilized.
Yes, that's correct. And also that there's not duplication between laboratories of doing the same type of rare test. There could be better distribution of resources, I think. So, well, now we can ask Professor Lisa Borman, who is the incumbent of the AMPATH chair at the University of Pretoria, and who has been the silent face of this meeting today. She organized this with main input by Helen herself in terms of the detail. If Lisa could perhaps summarize the key points.
Thank you, George. I appreciate the opportunity to summarize the knowledge and the personal experience that was shared with us today. So as the AMPATH chair in human genetics, we strive to, at the UP AMPATH Translational Genomics Initiative, to do translational genomics work. And this theme was really fitting what we want to do. So we discussed today whether NIPT is a pipe dream or is it an essential service that everyone should have access to. So Dr. Helen Malherbe started off and the title of her talk was, what is the problem and why do we need NIPT? So Helen set the scene with definitions and explanations, and she reminded us that congenital disorders are of diverse origin. She gave us overwhelming stats numbers. Thanks, Helen, for that. But in the South African context, which is very important, she touched on epidemiological transition in South Africa and came to the conclusion that we are lacking capacity. And that is very critical to make a note of, especially in this UP Translational Genomics Initiative, where we aim to train medical geneticists, genetic counselors, medical scientists. And that is where we lack capacity. The gap between the private and the public sector, Helen made us aware of again. And she concluded using Down syndrome as the example for NIPT, and that we remain with a large number of questions that we can't answer. For example, how many are affected, diagnosed, screened, the lifelong cost of caring, and what is the cost of missing these cases. So Helen set the scene truly for the next speaker, who was Dr. Marcel Meiber from the from the AMPATH Trust. And Marcel gave us a very technical talk. Thank you for that, Marcel. I'm sure the science students who attended the discussion appreciated your talk. And she touched on the technical aspects that involves the NIPT, that is involved in the NIPT test that they use at AMPATH. And she made us aware that it is of clinical use and that it is an intermediate step between maternal serum screening and invasive diagnostic testing. The other thing that Marcel introduced many people to who may not be aware of cell-free DNA. Thank you for the clear explanation of that, Marcel. And the importance of the fetal fraction and how that influences the quality of the test. And that this is influenced, for example, by maternal weight. Then she moved on to the fact that NIPT uses next generation sequencing. And that is why these tests are expensive and they do take time. She touched on the generation of results, eligibility criteria, and result interpretation, which is quite a lengthy process. She made us aware at the end of the limitations of NIPT, which is critical. And that is that we should not lose the knowledge that it is only a screen and that we need to do a confirmation with a diagnostic test thereafter. And this should only be done with pre and post genetic counseling after informed consent. Then the next speaker was Dr. Nicholas Crisp, who gave us a good perspective from the National Department of Health. And he started off by giving us, if it's possible, a short summary of what the establishment of a National Health Insurance Fund entails. I know that he gave a very good talk on this. If you want to follow up on that, you could contact Helen. He is currently the Acting Director General, and he made us aware of what the NHI fund pool would consist of, a pool of public funds and private. And he reminded us the importance of the National Health Insurance Bill and what is contained therein. Firstly, what are the benefits and how are we going to pay for them? And then secondly, that the Office of Health Products and Procurement is also an important part of this bill. He reminded us that the fund would not purchase products, but that the fund would purchase services, where many of us are sitting. Then he reminded us that the health technology assessment is not something new and we shouldn't reinvent the wheel. We should share expertise across the globe and not do this alone. And the sophisticated services under which NIPT definitely falls need to be evaluated in terms of their cost effectiveness. And he then reminded us from the government perspective on what have they already done in this regard and what still needs to be done. And we were made aware that in the pharmaco field that they are already doing something there, and that devices and technologies under which NIPT counts probably would be the next steps. He said it's a long road ahead. We shouldn't go it alone. We should use the global wheels that have already been invented. And that sets the scene for Dr. Nematswerani Nolantandu, if I may call her on her first name. And she's from a private medical scheme, and she gave us the viewpoint of Discovery Health. And I was quite impressed with the summary of how Discovery assess new technologies, a very nice flow diagram that we have seen. And it's a clearly defined process. And she almost prepared us for what lies ahead if we want to submit such requests to medical schemes. She reminded us that the evidences that we may present medical schemes will be scrutinized. They will be interrogated by using a strict quality control process. They had a very nice pyramid of these quality of evidences, how they evaluate the quality of evidence. After that is approved by a medical scheme, they would then do a clinical filter and then the financial filter and health economics, weighing up against each other the cost and effectiveness. The good thing about her talk was that we could all be assured that Discovery is one of the medical schemes that have approved NIPT for most of the, she said, across all DHMS plan types, subject to meeting benefit entry criteria. So that is very good news to have heard from Discovery. And then last, but certainly not least, was Anneke van der Wetteren, who shared in a very personal experience with us in a highly informative way. Thank you, Anneke. You reminded us that these tests are reliable and risk-free, and also that mothers still have the choice to terminate or not, and that many mothers would choose not to terminate a pregnancy. So in conclusion, we heard the perspective from many people today on NIPT, and we have a view of the road ahead, what we need to do to get the very best service to the patient, who still remain the center of this all. Thank you. Over to you, George.
Thank you, Lisa. I certainly see that you listened very well, and I learned some more from today's discussions after your very good summary. Now, on behalf of the organizers of today's meeting, Helen Malherbe and Lisa Borman, I wish to thank all speakers and participants, the University of Pretoria, Future African Empath, the administrative and marketing assistance by teams from the latter two organizations working together, and last but not least, the able technical assistance of Louis Klitter Productions, who enabled the smooth coordination of today's proceedings. We remain interested to facilitate further discussions involving both private and state sectors interacting with health economists to ascertain the possible ways in which NIPT can be a feasible and sustainable health service, serving as many patients as possible. Today was just the beginning. Let's follow this up in 2022. Thank you.